Welcome to Simplified Medico. Let us discuss about disorders of eyelids. Anatomy of eyelid. Let us first discuss about functions of eyelid. The eyelid have three functions. The first one is these act as shutters and protect the eyes from injuries and excessive light. And the second function is they spread tear film over cornea and conjunctiva. And the third function of eyelid is they drain tears by lacrimal pump system. Parts of eyelid. So we all know that there are two parts. They are upper eyelid and lower eyelid. And the eyelid is divided by a horizontal furrow sulcus into an orbital and tarsal part. Position of eyelid. When the eyes are open, the upper lid covers about 1/6 of cornea and the lower lid touches the limbus. As we can see in the picture depicted here, we can clearly view limbus, which is a junction between cornea and conjunctiva. And when we open our eyes, the upper lid covers 1/6 of cornea. Canthi. As we can see in this picture, the medial canthus is blunt. The lateral canthus is sharp. Palpebral aperture. The space, elliptical space between the upper and lower eyelid when the eyes are open is known as palpebral aperture. It measures about 10 to 11 mm vertically and 28 to 30 mm horizontally. And the important structure here is tarsal plates. The tarsal plates are fibrous structures which support the thinnest skin present above the eyelid. In the first point, we discussed the parts of eyelid, that they are orbital part and tarsal part. As we can see here, the orbital part is present between eyebrow and eyelid, and the tarsal part is present in the upper eyelid. Lid margin. This is known as lid margin. Lid margin is divided into two parts by a structure known as punctum. Punctum is nothing but a hole. We can view punctum it is present in everyone. We can view it by focusing a huge amount of light into the lower eyelid by pulling the skin under the eyelid, pulling down the skin under the eyelid. Like if this is your eye, you have to pull the skin under it, then you can view the lid margin in a better view. Then we have to focus the light towards the lower eyelid, then we can see a hole that is known as punctum. Clinically, it is used for sac syringing. It divides the lower eyelid into two halves. It's nothing but a hole which is connected to our lacrimal drainage system. So let us see about a gray line. Gray line, medial and lacrimal portion is rounded and devoid of lashes or glands, and the lateral and ciliary portion consists of a rounded anterior border, a sharp posterior border, mucocutaneous junction, and an intermarginal strip between the two borders. The gray line is present in the lateral ciliary portion, Gray line, it is also known as intermarginal sulcus. It represents the underlying muscle known as muscle of Raylan. Just anterior to the tarsal plate, it is present, the muscle is present, and divides the intermarginal strip into an anterior strip bearing 2 to 3 lashes and a posterior strip on which opening of meibomian glands are arranged in a row. The splitting of the eyelids when required in operations is done at the level of gray line. Gray line is nothing but a line which divides the orifice of meibomian glands and eyelashes, as we can see in this picture. Let us discuss about structure of eyelid. From anterior to posterior, it consists of skin, subcutaneous areolar tissue, layer of striated muscle, submuscular areolar tissue, fibrous layer of non-striated muscle, and conjunctiva. So if we remove the skin from it is the order from anterior to posterior. So if we remove the skin, we can see subcutaneous areolar tissue, and if you remove the subcutaneous areolar tissue, we can see layer of striated muscles. Like that, the meaning of anterior to posterior is that. And let us discuss this in detail. Skin is elastic, having a fine texture, and is thinnest in the body. The skin above the eyelid upon the eyelid is thinnest and elastic. And the second layer is subcutaneous areolar tissue. It is a loose connective tissue containing no fat. It is readily distended by edema or blood. Let us discuss about the third layer, that is layer of striated muscle. It consists of orbicularis muscle and levator palpebrae superioris muscle. As we can see in this picture, we can see the orbicularis muscle and levator palpebrae superioris muscle is hand drawn. The orbicularis muscle is having three portions. They are orbital part and preseptal part and pretarsal part. As we can know, already discussed in above, that our eyelid is having tarsus, and the orbicularis muscle part which is present above the tarsus is known as pretarsal part, and above the orbital part is known as orbital part, and then preseptal part, it is present anterior to septum orbitale and is loosely attached to it. At the junction of preseptal part and pretarsal part, a palpebral furrow is formed as hand drawn in the diagram. And levator palpebrae superioris muscle is present in the upper eyelid only. It arises from the apex of the orbit and is inserted by three parts on the skin of lid: anterior surface of the tarsal plate and conjunctiva of superior fornix. It raises the upper lid. It is supplied by a branch of oculomotor nerve. So the levator palpebrae superioris muscle, origin of it is apex of the orbit, and the insertion, it is inserted into three parts: on the skin of lid, anterior surface of the tarsal plate and conjunctiva of superior fornix. And the function of levator palpebrae superioris is to lift the eyelid, and nerve supply is by oculomotor nerve. And the fourth layer is submuscular areolar tissue. It is a layer of loose connective tissue. The nerves and vessels lie in this layer. Therefore, the clinical significance is when to anesthetize the lids, the injection is given in this plane. And the fifth layer is fibrous layer. It is having two parts: central tarsal plate and peripheral septum orbitale. The tarsal plate. These are two plates of dense connective tissue, one for each lid, which give shape and firmness to the lids. The upper and lower tarsal plates join with each other at medial and lateral canthi and are attached to the orbital margins through medial and lateral palpebral ligaments. In the substance of the tarsal plates lie meibomian glands. Meibomian glands are also known as meibomian tarsal glands, which lie in the tarsal plate as seen in this figure. And septum orbitale. It is also known as palpebral fascia. It is a thin membrane of connective tissue attached centrally to the tarsal plates and peripherally to the periosteum of the orbital margin. It is perforated by nerves, vessels and levator palpebrae superioris muscle, which enter the lids from the orbit. Layer of non-striated fibers. It consists of the palpebral muscle of Muller. So, layer of non-striated muscle is having one muscle known as palpebral muscle of Muller, and layer of striated muscle is having two muscles known as orbicularis muscle and levator palpebrae superioris muscle. Let's discuss about layer of non-striated muscle. It lies deep to the septum orbitale in both the lids. In the upper eyelid, it arises from LPS muscle, and in the lower eyelid from prolongation of inferior rectus muscle. So, the origin in upper eyelid is from LPS muscle and in lower eyelid from inferior rectus muscle. We know that superior rectus and inferior rectus are the muscles which directly attach to the eyeball, and we already seen the position of LPS here. So in upper eyelid, the muscle of Muller will arise from LPS muscle, and in lower eyelid it is from inferior rectus muscle, and it is inserted on the peripheral margins of the tarsal plate. It is supplied by sympathetic fibers, and its paralysis leads to Horner's syndrome. Horner's syndrome is a condition which is caused by paralysis of Muller's muscle characterized by twitching. And the last layer of eyelid is conjunctiva. The part which lines the lids is called palpebral conjunctiva. It consists of three parts: marginal, tarsal and orbital parts. Beginning of the marginal conjunctiva marks the mucocutaneous junction. As we already discussed above about mucocutaneous junction, let us discuss about glands of eyelids. There are four glands. They are meibomian glands, glands of Zeiss, glands of Mole, and accessory lacrimal glands of Wolfram. Let us first discuss about meibomian glands. They are also known as tarsal glands. They are present in the stroma of tarsal plate, arranged vertically. They are modified sebaceous glands. They Their secretion constitutes the oily layer of tear film. Glands of these, they are also sebaceous glands which open into the follicles of eyelashes. Glands of mole, they are modified sweat glands situated near the hair follicles. They open into the hair follicles or into the ducts of these glands. They do not open directly into the skin surface. And accessory lacrimal glands of Wolfram, they are present near the upper border of the tarsal plate. Let us discuss about blood supply of eyelid. Arteries. The arterial supply consists of arcades. Uh, the marginal arterial arcades are formed by medial and lateral palpebral artery, and superior arterial arcade is also present. These two arcades will supply the arterial blood. Let's discuss about venous drainage. In post-tarsal part of the all the blood in the veins drain into ophthalmic veins, and in pretarsal part all the blood will drain into subcutaneous veins. Let's discuss about lymphatics. Lateral half of lids preauricular lymph nodes are present, and in medial half of lids submandibular lymph nodes are present. Let us discuss about nerve supply. Motor nerves and sensory nerves. Motor nerves. Facial, oculomotor and sympathetic fibers are responsible for motor movements. The facial nerve supplies orbicularis muscle. The oculomotor nerve supplies levator palpebrae superioris muscle. And the sympathetic fibers supplies Muller's muscle. Sensory nerves. They are derived from branches of trigeminal nerves such as lacrimal, supraorbital and supratrochlear nerves for upper eyelid, and infraorbital nerve with infratrochlear branch for lower eyelid. Let us discuss about congenital anomalies of eyelids. So these are the abnormal eyelids which are formed at the time of birth. The first one abnormality is congenital ptosis. Congenital ptosis. Ptosis means dropping of eyelid. And congenital coloboma. It is characterized by a full thickness triangular gap in the tissues of the lids. And the treatment consists of plastic repair of the defect. And the third one is epicanthus. It is a semicircular fold of skin which covers the medial canthus. It is a bilateral condition and may disappear with the development of nose. It is a normal facial feature in Mongolian races. It is most common congenital anomaly of the lids. Treatment consists of plastic repair of the deformity. And the cryptophthalmus. It is a rare anomaly in which eyelids fail to develop and the skin passes continuously from the eyebrow to the cheeks, hiding the eyeball. It's simply the absence of eyelids. And microblepharon. In this condition, eyelids are abnormally small. Epiblepharon. Congenital anomaly in which a horizontal fold of tissue rises above the lower eyelid margin. It usually disappears with the growth of face and needs no surgical correction. And euryblepharon. Unilateral or bilateral horizontal widening of palpebral fissure. It is usually associated with lateral canthal malposition and lateral ectropion. And congenital ankyloblepharon. It is a rare anomaly. It is a rare anomaly in which single or multiple strands of connective tissue join the upper and lower eyelid margins, anywhere but never at medial and lateral canthi. Such a congenital ankyloblepharon is also called ankyloblepharon filiform adnatum AFA. It should be surgically divided in to prevent amblyopia. And dystichiasis is a rare anomaly in which an extra row of cilia occupies the position of meibomian glands, which open into their follicles as ordinary sebaceous glands. These cilia are usually directed backwards when rubbing the cornea, should be electroepilated or cryoepilated. So, cryoepilated means here we use cryoprobe, and electroepilated means removing of the eyelids with passing of electricity. And the last two congenital anomalies are congenital entropion and congenital ectropion. See, the eyelids of eyelids are present like this, and eyelashes must be outwards. If the eyelashes will grow inwards, it causes congenital entropion. And if the eyelids grows outwards, it causes congenital ectropion. And misdirection of eyelids is known as trichiasis. Outward turning of the lid margin is called as ectropion, and misdirection of eyelashes is known as trichiasis. These are the normal conditions which abnormal conditions which are normally seen in eyelids. Means these are the important conditions for exam. These can be asked in exam. Out of which congenital coloboma is a rare condition. Remaining all can be seen. Cryptophthalmus is also a rare condition. Remaining all can be seen in people commonly. Thank you.